let me first say thanks to the Colombian Congress of Interventional Cardiology, to the organization. It's my pleasure to be here with you and share some knowledge. I was very interested and delighted with the last presentation from my colleague about fusion in terms of imaging, and I think this next in the next few minutes we're going to be sharing some information that it's kind of complementary in terms of new technology. So robotic, this is my disclosure, and robotic PCI. This is the brief history of. This is a brief history of robotic PCI. Actually, for coincidence, it's been almost 20 years since the company started in Israel in 2002. Exactly 20 years, actually. So. In 2002, this company was founded in Israel, and so it's exactly 20 years. If you take now that we are in 2022, another landmark was in 2008 when the first in-man robotic assisted PCI was performed, and exactly 10 years after, in 2018, the first in-human remote PCI study was completed in India, which means that this was the first time a patient was had his PCI in a remote place, and the doctor was outside of the hospital. So this is the real future. We're going to talk about this later in the last slides. We all know that Grunzig was the pioneer in our field when he performed the first PCI balloon angioplasty, actually, in 1977. It was a left main PCI. And after this, we can consider that all the devices changed, including stents, rotational atherectomy, laser, and many things. But in terms of equipment, we are continuing to use in our everyday practice. We continue to do the same thing. The only big change we might have in this field in terms of hard equipment is robotic PCI. This is a breakthrough because it will change, and it not only will, it already changes the way we perform PCI in terms of not being in front of the patient all the time and avoiding radiation. So when we compare the two ways of performing a angioplasty, a percutaneous procedure, the today's cath lab environment where we have high radiation exposure and significant fatigue and orthopedic strain. In the robotic cath lab, we see here, if you can see the screen, actually, I hope you can see that the doctor is outside of the cath lab of the operation room, and the robotic room has the potential to avoid and to reduce fatigue and also prevent the radiation. Basically, in terms of assessing anatomy, the manual intervention means a struggle to see angiography. Robotic assisted intervention means close proximity, ergonomic visualization. To navigate to navigate a lesion, there is also a big change when robotic techniques are applied, and mainly to measure the lesion. We are not using eyeball estimate when we do robotic PCI. Is a sub-millimeter measurement that we do, that the equipment allows you to do, actually. And for stent deployment, we can exactly choose the precise position and place the stent exactly in the position that we should, based on IVUs, on any other information, not as we do in our daily practice, where we are very precise, but not in a sub-millimeter measurement. This is basically the environment. There is a bedside unit. Here we see the bedside unit. Of course, the femoral or the radial puncture needs to be done, and the catheter needs to be inserted by a human person. It's not something that goes on and on. It's someone has to go there and insert the catheter, and someone has to be in the room, inside the room, to change, replace a catheter to a balloon to the other, and to place the stent. But the main operation is performed outside of the operational room, outside the cath lab itself, and in the interventional workstation. Okay. Of course, this will prevent and decreases a lot the radiation for all the operators, and decreases also radiation to the patient, because the procedure can be done in the fastest way. This is the robotic drive, the screen, and the physician who is operating the corriendo system, which now belongs to Siemens, is outside room, usually in the control room, where he is able to control everything, and in terms of deploying the stents, moving the balloons, pushing out the guide wires, and everything. The only thing he cannot perform here outside is the engagement of the coronary. This has to be done, the guiding catheter engagement has to be done inside by someone before the procedure is started. Okay, this is exactly the control console that the person who is performing the procedure will have. The turbo button that moves faster. The joystick is like almost like playing a video game, and for one joystick for the balloon or stent, one joystick for moving the guide wire, and another one for moving the guiding catheter. There is a touch screen and an emergency button to stop. So the system is compatible with 5 to 7 French guiding catheter, all 14 inches guide wire. It's not available yet for all 18 and all 35 guide wires, which can limit a little some of the some of the interventions performed in the legs. For example, they are usually performed we're using all 35 guide wires. But in the near future, this will be possible. And also, it's possible to advance and retract balloons and stents. Usually, it's recommended to use a co-pilot system as a Y connector. I think we can go on. This is the single-use cassette. Each procedure has to be for each procedure a single-use cassette has to be employed, and this is attached to the robotic drive, and it allows simultaneous and independent movement of up to 3 devices. So in terms of proven benefits, we could say that the literature has some studies, like the core PCI trial, that demonstrated a 99.1, almost 100% clinical success in complex cases. Another study in circulation demonstrated 20% reduction in radiation. And the PRECISE trial demonstrated a 95% reduction in radiation for the primary operator, and also allows a precise measurement of the lesions, which can reduce measurements, errors, and needs for extra stents. So this is another big advantage. When you have precise measurement of the lesion and the extension of the lesion, you can prevent of using more than one stent in situations where if you're doing a visual analysis, you might be using a second stent. So this, I think we have already mentioned that it allows guide wires, guiding catheters, and rapid exchange devices, and it's already been used in over 9,000 cases across at least 65 cardiovascular and vascular programs worldwide. In terms of scientific evidence, there are more than 58 publications around, and basically the main advantage is in my opinion at least, the main advantage is a 95% reduction in radiation exposure for the primary operator. There is no way we can reduce more radiation, and we know that radiation is one of, if not our, for the operator, if it's not the, in my opinion, I think it is actually our biggest enemy in terms of creating diseases and so on. So I think we should be very, very conscious about radiation exposure. Many of us, unfortunately, have colleagues who develop diseases. I unfortunately had two colleagues who developed leukemia for no other reasons. One unfortunately has died, and another one fortunately is alive, still working, but developed also leukemia. And we know that other doctors around the world have developed similar problems with radiation. There is now the Sky Precision Registry, which is a multi-center post-marketing registry for the evaluation of this system, showing a clinical success of almost 100% again, technical success of more than 90% of all lesions treated without unplanned manual conversion. This is, for me, is another very, very important thing. The crossover for manual conversion to manual procedure is usually less than 10%. So it's very safe, and very seldom once you start the performing robotic PCI, you're gonna have to give up and cross over to a manual procedure. There are many different options and capabilities of the system, like the rotate and retract, the wiggle, the spin, and the daughter for the wire. But I think one of the most interesting one is hope you can see the screen, is the rotate and retract ROR, as I say, which is the guide wire navigation that can reduce navigation time in difficult anatomies such as tortuous vessels. Why I'm stressing out the importance of specifically this feature, this characteristic. I show you why once the video is off. The video is showing how the wire is being rotated through, backwards, and forward. And the reason I'm saying that this is a very important feature, it's because this single feature, rotation and retract, has been shown to potentially reduce wire time in more than 53%, in 53% of the cases. So you not only you are using a system that prevents radiation because you are operating outside of the operational room, but you are also doing a faster the procedure in a faster way, and this is also going to reduce radiation to the patient itself, because you reduce the time to cross and to maneuver the lesion, and this is a feature that is incorporated in the newest system. So finally, this is just a short timeline where the procedures were performed, and I would stress this procedure performed in India, where the patient was 20 miles away, the 2018 procedure, using the Wi-Fi, and now with the 5G cellular systems, that mobile system that we have, I think in Colombia we have, in Brazil we do, the Wi-Fi or fast technology, fast cellular systems will allow us to perform the procedure outside of the hospital. And this being published in the Lancet journal one in 2018. So finally, to conclude, this is my take-home messages. Robotic PCI definitely increases accuracy with artificial intelligence allows more precise movements. And can be very important for complex situations like such as CTO, where we struggle to cross a lesion and we usually take a lot of radiation. And radiation exposure definitely is reduced for medical team and for the patients, and definitely allows fine-tuning with detailed lesion measurements and allows crossing the lesion in very tortuous anatomy. Hope you could appreciate this talk, and again, thanks a lot for the opportunity to share with you this knowledge.